There's certain kinds of diseases that can be caused by the environment to the lung. Okay, so these are considered environmental causes. The diseases can be usually caused by inhaling these particles in the air. Okay, things like atmospheric pollutants. Okay, which is if you live in a city and instead of you lived in a farm, if you took the person's lungs out, same kind of genetics and everything else. A person that lived in a city that never smoked, they would still have carbonaceous material in their lungs. Their lungs would be partially filled with black material versus somebody out in the open who was exposed to a lot of these atmospheric pollutants would have nice pink lungs even at the very late stages of their life. So these pollutants do affect the quality of your existence. Okay? Carbon monoxide is one of the ones that is a very high culprit because it has 200 times affinity for binding to hemoglobin. Okay? The danger of carbon monoxide is that we cannot pick it up with pulse oximetry. The only way to pick it up is by you have to draw a blood gas for it. Okay? It also shifts the oxygen dissociation curve to the left, and as a consequence holds the carbon monoxide at a higher percentage and it doesn't allow the oxygen to come on board. It's really produced from many things, but it's usually from incomplete combustion of carbons and fuels. In addition to that, you have other things that you can inhale, such as gases, such as nitrogen oxides. They produce when fossil fuels are burned at high temperatures. They can cause inflammation of the eyes, upper respiratory tract. They get a tracheitis, bronchitis, and pulmonary edema. You also have sulfur oxides, hydrocarbons, particulate matter. You also have photochemical oxidants and cigarette smoke. All these are inhaled particles. And the cigarette smoke alone, let's say, has almost like 600 different toxins in it. So it's not just one toxin that's inside cigarette smoke. There's a considerable amount of them. What you're literally talking about in environmental is how far is this droplet going to get into the patient. Okay? And when you break it down is how it actually deposits in your lungs. It has to do with the actual particle size. Okay? The bigger the particle size, the easier your body is able to handle it most of the time. Okay? The other thing that's important for you to understand is that turbulence is a big way that your body tries to protect you from your outside environment. Okay? Most of you in this room, about 90% of you, will breathe through your nose. Okay? About 10% of you tend to breathe through your mouth. The people that tend to breathe through their mouth are much higher risk for developing asthma. They are at much higher risk for developing bronchitis. They're more likely to develop pneumonia. They're also more likely to develop things like epiglottitis. Okay? Why is that? Something so simple as just breathing differently. And the answer is that the nose does a very good job of slowing down velocity of airflow as it travels through your lungs, before it travels to your lungs. And what that means is that particles of certain size will immediately deposit into your nasal mucosa and protect it from it going down the lungs. So if you're inside a fire and you're exposed to a lot of particulate matter, try to continue breathing through your nose, not through your mouth. If you are breathing through your mouth, at least put some piece of cloth over your mouth to try to keep some of the particulate matter from getting into your lungs. Okay? But your nose does a very effective job of doing this. Okay? So when you're looking at this, you can call it three different ways, which is impaction, sedimentation, and diffusion. And what they're really talking about is what area of the lung is going to be effective by these deposits. Impaction usually takes place in the nose. Sedimentation is usually in the trachea, and diffusion is taking place all the way at the bronchiolar level. Which is more dangerous? Diffusion by far is the more dangerous because that means the gas has already reached all the way down to the alveoli and may be extracted rapidly into your bloodstream. Impaction usually occurs with large size, particular size of 5 micrometers, okay, and usually represents the site of impaction around nasopharynx. Now, clinically, you have to ask yourself, why am I bothering you teaching this? This is more of a respiratory pathophysiology. How does this affect my clinical treatment of anybody? Well, most particles that we ask the patients to inhale are greater than 5 micrometers in diameter, believe it or not. Most medicines that we give are large. Okay? So understanding this concept will make you a better clinician. Let me give you an example. Let's say you're going to do a bronchoscope, or you're going to do an awake fiber optic on a patient. Okay? What we do for awake fiber optics is that we want to have the person inhale lidocaine, usually 4% lidocaine, and we ask the person to breathe it in. Most students that don't listen to this lecture or forget about this will just tell the person breathe. What did I just tell you most people breathe like? Most people breathe through their nose, right? 90% of you breathe through your nose, okay? So what will happen to all the lidocaine, which is over 5 micrometers in diameter, if I start breathing that way? It'll numb up the nose very well. Okay? It'll do a great job in the nose. But it'll do a terrible job of the larynx. Okay? So you have to ask yourself, how do I get more medicine into the larynx? And the answer is, treat them like an obligate oral breather. Let them breathe through their mouth. So you tell the person, well, here's what I want you to do. It's very important you do this because it makes the quality of the anesthetic better. Taking a big, deep breath through an open mouth and take a biggest breath as you can. And just keep doing that. And then breathe out through your nose. Okay? And that way it covers the nose on the way out, and it covers the larynx on the way in. Because now the big particle sizes are able to now sediment into the small airways and the trachea. Okay? So it's a simple little thing that nobody tells you about, but it makes a huge difference in how you actually administer an anesthetic. Okay, you can make somebody very comfortable just with 4% lidocaine without use of any needles if you know that trick. If you take that same medicine, you give it to somebody who doesn't know this, they will do it the normal way. They'll let the person breathe through the nose, and then they'll find out that they can't intubate them because it's so difficult. Guess why? There's no local anesthetic in the trachea, and much less is there in the larynx. So the person can't tolerate it. Okay? Now, sedimentation is basically a description of medium-sized particles, usually between 1 to 5 micrometers in diameter, and then that'll reach all the way down the small airways. And then you have really small molecules that are less than 0.1 micrometers, which is taking place. These are gases, basically, that are reaching all the way down to the alveoli. The mucociliary mechanism is very important to try to maintain this area so it keeps it cleaned. It's like having your own sweeper. It's housekeeping your lungs all the time. Okay? Mucus only operates in the conductive zone, okay, which means that it goes from basically the trachea, from larynx down to trachea, bronchioles, and all the way down to the terminal bronchioles. But beyond that, there's nothing after that. Okay? It's only in the conductive zone. Okay? Once it gets into the alveoli, there is no mucociliary mechanism anymore. What's cool about the mucociliary mechanism is it's got 2 components. It's got mucus, okay, and it's got cilia. Okay, cilia, if you don't remember this from your early biology, it's a little, basically like a little arm that is attached to a cell that beats constantly. It's what I call the fan. It keeps pushing the molecules upwards. And these things beat continuously, and they're constantly pushing the mucus upwards. Okay? The mucus, though, is actually highly specialized. It's not something so simple. Okay? It's produced by several kinds of cells. It's produced by the bronchial seromucus glands, okay, which is they're deep in the bronchial walls. And you also have goblet cells, which are from the bronchial epithelium. The mucus, though, that's formed, it's got 2 layers. It's got a gel layer, which is a superficial, thick, and tenacious component. And then the lower area where the cilia live is more aqueous. Okay? It has to be liquid because cilia do not beat in solid. They beat in water. It's actually, if you look at it, ciliated organisms, where do they live? They live in water environments. Because it acts like a little propeller, it makes them run around. Okay? So if the cilia has to beat against a very thick, viscous layer, it can't do it. So it has to have a very healthy, sol layer, which is a solvent layer, for this cilia to work properly. The mucus also has immunoglobulin properties, so it's an immunosuppressant, and it's also immunoprotective of your body. Okay? It's not immunosuppressant, it's immunoprotective, sorry. It's derived from plasma cells and lymphoid tissue that are in your lungs. Okay? Normally, the cilia move most of all the bronchial mucosa completely out of your lung every 24 hours. And you have to ask yourself, man, that's a lot of mucus if you think about it. Okay? Where does it all go? You swallow it. So you're swallowing mucus all day. Okay? Believe it or not. Okay? That's why if you have a bronchitis and you swallow your own bronchitic infected fluid, it can give you diarrhea, GI sicknesses, and everything else. Okay? So, it all sort of comes together if you start thinking about it. Okay? Now, the other thing that's bad about this stuff is that the mucus has this quality that has this liquid state and this very thick state. Okay? In certain diseases like asthma, the mucus can become hyperviscous. Okay? And you can see that when kids cough like this, they can't get the stuff out of their lungs. And what they're taught is that they're given a lot of times a drug called Mucomist. Mucomist is very dangerous. You got to be very careful with it. Okay? When you give it to somebody, and I've seen it happen to me when I was a kid. I got Mucomist when I was a kid. I almost drowned in it. Okay? What happens is the mucus basically dissolves. That's what the Mucomist does. It dissolves the gel layer and makes it liquid. Okay? And when the person then coughs, okay, the mucus will actually come up into their mouth. Okay? And you may actually be forced into the position where you have to reach into their mouth and pull the mucus out. Okay? And the mucus will actually form a cast of your lungs. When you pull it out, the whole thing will come out like a giant, it looks like a giant web coming out of a human being. It's really scary to watch when you do it, but immediately the person starts breathing immediately better because it's completely obstructed their airway. But it's something you have to think about. Don't think of mucomist as benign. It can be a nightmare. Okay? It can also be a nightmare if you have somebody intubated. Okay? I've seen this happen where the mucus just dissolves and it just plugs up your endotracheal tube, and now you can't even ventilate through the endotracheal tube. The only treatment of that is pulling the endotracheal tube with somebody desaturating. You can imagine how fun that's going to be. Okay? So just be careful if you use this stuff. It works really well, but it's got its limits. The other bad thing about Mucomist is that it also causes an inflammatory reaction, and most people get redness in their airways and conductive airways, which doesn't necessarily make them very happy. The mechanism that's also responsible to clean up your lungs is the alveolar macrophages. Usually these guys are found down at the alveolar level. Okay? Their job is basically to sort of make up for the lack of mucociliary mechanism that's in the alveoli. Okay? They're really there to pick up any dust that's down there and clean up and keep the area dry. And they're transported when they're finished up into the lymphatics. And they can go sometimes, and they can sometimes walk up and go into the conductive zone themselves to get rid of themselves. The alveoli pretty much remain sterile due to these macrophages because they do kill the bacteria, which is very good. Okay? When this system becomes overwhelmed, that's when you get what's called pneumonia. Pneumonia is an infection, but it's really a description of water in the lungs. Okay? And if you look at the water, you'll see bacteria. There's, of course, a bacterial infection, and you also see large numbers of white cells. Now, there's different disease causes now that can actually travel down. This is what we're going to talk about specifically. Is things like coal workers. Okay, have you seen a coal worker ever go into a mine? When they come out, their face is completely black. That blackness is from coal dust that actually they've been inhaling the whole day. Eventually, the coal particles basically accumulate around the terminal and respiratory bronchioles, and it leads to progressive massive fibrosis. So this becomes a restrictive disease process. The person usually develops dyspnea, coughing, and may terminate in respiratory failure. What you see in simple pneumoconiosis, you get small reductions in FEV1 and a rise in residual volume and a fall in your PaO2. Eventually, you get a mixed obstructive and restrictive disease with increased hypoxemia, corpulmonal, and eventually respiratory failure. Another thing that also occurs in mines is silicosis. Okay? And silica is basically like a glass fiber that you can cause severe fibrous reactions in the lung. Clinical features are coughing, severe dyspnea, and progressive massive fibrosis, and there's also an increased risk for developing TB. Pulmonary function is a restrictive defect in this kind of disease process, and eventually also the coal miner's pneumoconiosis is going to give you a mixture, but the terminal event usually is restricted. Then you have asbestos fiber, and asbestos fibers are really, unfortunately, prevalent pretty much in many of our buildings still. It's gotten better in the last few years, but specifically a big problem in the military because it was used for almost everything as a retardant against fires. Okay? So all the Navy ships and a lot of our Navy personnel got exposed to asbestos. If you see the old World War II pictures, every once in a while you'll see the gunners firing, and the gunners always have these white hoods that they're covering their heads. You ever seen that? You don't know what I'm talking about. Okay. Well, what the gunners in World War II would do is, and I knew some of the guys during that time when I was a younger kid, is they would put these white sheets that would go over their face, and they would have their eyes exposed. Okay? And these white sheets basically are there to protect them from the flash injury when the gunpowder goes off. Okay? What they didn't tell the poor gunners is that all those things were made out of asbestos. Okay? So these guys had these hoods over them, and they were inhaling asbestos fibers. And many of these people developed mesothelioma and died from asbestos-related diseases. Okay, not something you want. The other place where you see asbestos a lot is in your actual piping for insulation material as well. As long as it stays in the compact form where it's cemented in place, there's no risk to you. It's only when you start seeing the fibers beginning to float in the air, that's when you have to worry. So if you have asbestos in your house, the thing is you don't mess with it. You go get a company who is basically specialized in that area, and they'll wear full suits on to remove the stuff. Okay, and they're supposed to measure the air quality after they're done removing it. I had a few years ago when a father came in, and his son had blown. The kid was 6 years old, and his lungs were completely whited out. We were trying to figure out what the heck had happened, and the kid died on us in about 3 or 4 days in the ICU. So they sent him to autopsy because they couldn't figure out what had happened, because that's something you don't see in a 6-year-old. And when they did it, they found the kid's lungs were filled with asbestos. Okay? So he developed into a fulminant ARDS. And the question was, why? How did he get exposed to it? And when we asked the father again, how did he get exposed to asbestos? And he said, well, that's the most expensive brake job I've ever done myself. He had taken the brakes, he had taken the wheels off his car, and the kid had been walking around looking at what he was doing, and he was teaching him. And one of the things that he did was he would take the air hose and clean up the brakes, which I've seen done at brake shops. And you'll see the asbestos fiber from the brake pads go flying everywhere. And the kid had been right there and inhaled all of it because he was a shorter height. So he sucked in all this asbestos and killed him dead in the heck. So if you do work on your car and you're working on brakes, guess what? Keep your kids away. It's an important lesson. Okay? Asbestos-related diseases will give you a very diffuse interstitial fibrosis. And you also get bronchial carcinoma as well as pleural disease called malignant mesothelioma, because then the fibers will actually penetrate and go all the way through the pleural space and cause carcinogenesis to take place. Other forms of pneumoconiosis can include byssinosis, which are exposure to different things like cotton dust exposure. It causes histamine release in the lung and acts very similar to asthma. You also have occupational asthma. If you're a person who likes to build model airplanes, you should, when you're working on balsa wood and sand, you should also wear a mask. All these things that you don't consider. If you're working on concrete, you should really wear a mask. I was doing that the other day. And of course, I don't follow my own advice sometimes. I paid for it the last night. So you do get the asthmatic component within about 6 to 8 hours after exposure to the stuff, because it does get all the way down to the alveoli, or not all the way down to the terminal bronchioles, and that's when you get, start acting asthmatic. You also may have neoplastic disease that takes place with exposure to this stuff, especially when you've got to think about hay exposure or things like they expose you with a lot of funguses. Those are the things that are going to cause more likely carcinogenesis. The way funguses have protected themselves, and they do a very good job, is that they have to compete. The other competing friends that they have are what? Bacteria. Okay? So fungi are competing with bacteria for survival. And the way the fungi have actually done this is they've done chemical warfare against bacteria. They release toxins which cause physical changes to DNA fragments of bacteria. Okay? So if you're inhaling mold and funguses, it's going to begin to attack you in the same way. It doesn't realize that you're a human. It just sees you as another possible large bacteria. Okay? So cells that are around that area are going to get damaged by this fungus, okay, by these fungal toxins. It's not the fungus that's killing you. It's the actual teratogens released by the fungus that are killing you. Okay? And that converts your cells into in a phase that are basically cancerous, where they don't stop reproducing, and it overtakes and kills you. Okay? What is cancer, basically? Cancer is is a disease process where the cells, instead of terminating, they do not. So there's actually cell lines that we have right now that we use as cancer cell lines for research that have been alive for 50 years, and the patient who donated has been well dead over 10 or 20 years. Okay? And they expect that cancer line to be in existence for maybe 1,000 years. They theoretically think that's possible. Okay, so if you have cancer cells, they don't stop reproducing. There's neoplastic disease of the lung can be basically designated based on cell type. You have your small cells. Small cells are oat-like cells that are about 1/3 of the bronchial cancers. They're highly malignant with rapid dissemination. They're seldom seen in the peripheral lung and usually do not cavitate. Okay? This is a bad one because it's difficult to treat, and because it becomes highly disseminated, usually it's highly malignant. Non-small cell carcinomas can be broken down into the different cell types of squamous cell, large cell, adenociliary, and alveolar cell carcinoma. By far the most common is the non-cell squamous cell carcinoma. Okay, that's the most common. Is it treatable? Yes, you can actually excise parts of the lung to get it out. Radiation seems to be a little more responsive, and it doesn't get metastatic as early as small cell. So small cell carcinoma is much more lethal than the other squamous cell is. Clinical features is an unproductive cough. You usually see hemoptysis, which is coughing with blood in it. That's not a good sign. Anybody that sees blood in their cough, you should immediately go see somebody. It might be an early bronchial carcinoma that you can treat, so you need to get involvement quickly. If the person develops hoarseness, that's not a good sign because usually it means involvement in the recurrent laryngeal nerve. That's usually a Pancoast tumor, P-A-N-C-O-A-S-T. The Pancoast tumor is a lung tumor that's usually found in the right upper lobe, okay, and it begins to compress on the right recurrent laryngeal nerve and causes hoarseness. Okay? If you start seeing dyspnea, that's usually a very late sign. It could be that the bronchus is not completely occluded, or it becomes the lung cancer is infiltrating into the lung itself, and that causes significant problems. Pulmonary function, depending on what exactly it's doing, sometimes it can be unaffected, other times it starts showing obstructive disease process if it's a bronchial carcinoma. Infectious disease is the next topic. We're almost done in this section. You have pneumonia. It's an inflammation of the lung parenchyma with alveolar filling by exudate. It's very considerable depending on the causative agent, so you have many different causes. So pneumonia is just a general description. It doesn't give you the etiology. You have to start finding out what is likely. That's what makes you have to ask a lot of questions to the patient. Okay, you know, what's it was like before the last week. Basically from symptoms you can pick up it's a virus or a bacterial infection. My personal favorite, which I always did, is I immediately asked people to cough and spit into a cup by deep coughing, and then I immediately ran downstairs and I did my own gram stains. I used to find out more bacteria more rapidly than any other method. If you send it to a microbiologist, my wife's a microbiologist, so I know a lot of this stuff because she would come in and complain about how doctors are so stupid. The doctors would call usually within 24 hours, and they'd say, "Where's my culture?" So the microbiologist would go over the petri dishes, and they say, "Grow, grow." Yeah, so no, it doesn't grow that fast. Okay, it takes 48 hours for the bacteria to grow in a petri dish, so to be able to identify them. Okay, so you're already delayed by 48 hours in your treatment. So the best treatment is sending for your specimens. Yes, it will take 48 hours. But your initial treatment should be based on your gram stains. If you see a bunch of gram positives, then you treat with your antibiotics that are appropriate. If you see a bunch of red ones, and you're in the gram negatives, okay? If you see nothing, then it's viral possibly or fungal. So it gives you really a good idea really quickly what you're dealing with. Now, if you see everything, then you're really in a bad place, okay? Because that person could have aspirated oral flora into their lungs, so that's a much more difficult problem to deal with sometimes. Okay, if you do get a situation like that, always ask for a gram stain. How many people have worked? You guys all worked in SU. How many people you saw ever go downstairs to get a gram stain? It's almost like nobody does it. It's unbelievable. It's very rare that you see residents do that. As a fellow, I learned my lesson. I started immediately doing it, and I started teaching all my residents how to do it below me, and they were always amazed, like, how come we're getting so much better, response rate. It's like, yeah, well, because we're hitting him with everything, and we know it's a gram-positive, it's a gram-negative, we're hitting him with everything, and we don't see anything, we're going after the antivirals right away. We're not going to give him everything. So we tend to be more selective, which I think is a little safer for a patient. TB is a big problem for us. It's a big risk, especially if you're working with underprivileged individuals or people from third world countries. There's some TB now that's coming up from Mexico and Latin America that's untreatable. It's very scary stuff. In Miami, they had a whole unit full of nurses get all TB because when they installed the fan, they installed it backwards. So instead of the air being extracted out, it was being pulled into the room. So the TB wasn't going anywhere. It was hyper-concentrating, so everybody that worked in that unit got TB. So don't take it lightly. TB, if you hear somebody with TB, cover yourself up. The other thing with TB that's very serious is it causes miliary TB, which means that the inside lining of their peritoneum and their thoracic cage will actually develop these little white spots all over the place. I saw that a few years ago when a surgeon opened up the abdomen, and the guy had acute abdominal pain. And when he opened it up, it looked like somebody had just dropped little white pellets all over his bowel. And I knew immediately what it was, and I said, you know what, stop. Everybody's got to get a TB mask on. So we all run out of the room, put on our TB mask on, and sure enough, he came back grossly positive for tuberculosis. And if that milia, the reason it's called milia is how many people have eaten Italian soup? Italian wedding soup. Okay, the Italian wedding soup, when they put it in, is they take this little wheat and they throw it on top and they cook it. So when you look at it looks like little white stuff floating on top of the surface of the Italian wedding soup. That's milia. Okay, that's why it's called miliary TB, because all the pathologists were starving of old. So everything was described with food. Okay, so it's kind of weird, but if you want to see a pathologist at work, they'll have a sandwich as they're doing their specimens. They don't really mind. They don't mind eating while they're doing their autopsy work. It was a very strange world some days. Anyways, so tuberculosis is one of those bad things. It tends to occur in the upper lobes of your lungs because it has the most oxygen levels. So TB actually likes high levels of oxygen. Is it bad for your anesthesia machine? Your anesthesia machine has never had any bacteria or any form of TB ever grow out of it. Anytime we've tried to take somebody and expose the machine to TB and then take it and then swab it and check it for TB, nothing can live through the CO2 absorber. Okay? The only thing you have to change, of course, is your tubing. Okay? That you can grow stuff, but once it gets into the machine, the CO2 absorber pretty much kills everything for you, which is kind of good. It doesn't mean that you got to be like, don't care. It means you just got to be a little bit careful, but don't freak out. Don't worry about the next patient. If you really want to freak out and worry about it, then change out the CO2 in between cases. Make sure that you're wearing your mask still if you're that worried, to make sure that you're not, contaminating the area, and put it in a red bag. Okay, just to make sure. Pulmonary involvement in AIDS. Oh, just, in AIDS, what a nightmare. When I was going to medical school, we just got in when when AIDS was coming into play, and before I actually was admitted into medical school, they told us, they said, you know what, you got to sign here in the dotted line that you're not going to bail out on patients when you finish up your residency training. When you finish up your training, I said, what do you mean? He says, well, there's some doctors that are just refusing to take care of these people because we don't know what the heck the cause of it is. So you already had accept when you had walked in that there's a potential life-threatening disease that may kill you, that you may not know what causes it. But you know what? That's an oath that you have to keep in your mind, okay? When there's bad things happen in the community, you can't run. You got to stick to what you need to do. Just take care of people. And does it mean that you have to die in the process? The answer is no, but you have to protect yourself, but you still got to help. Okay, that's your job. Okay, just to show you how serious it is. At least when I was in ICU, they lost a whole unit of people up in New York from Ebola. A person came from Africa, got to the United States. They went into the ICU because they were spitting up blood, and nobody took protective measures, and they were all dead. The 2 nurses and the 2 docs that took care of the patient died on the spot, usually about a week later. Okay, so make sure you're protecting yourself. If you hear somebody coming in with something weird, trust me, consider it dangerous. It may kill you. Okay, so don't take it lightly. Okay, AIDS is one of those things that you get immunosuppression. And that means anything that's possible, we'll get it. Okay? The reason that the United States became the #1 identifier of AIDS, okay, wasn't because we're the one that produced it, despite what some of the world countries say. Okay? It's simply because we're the ones that were doing transplants. Okay? The doctors that were doing transplants were immunosuppressing the hell out of people, and they were beginning to see something that was unique. It looked just like AIDS. So immunosuppressed people basically look like AIDS victims. Okay? So you can get cryptosporidium, you can get any kind of weird virus can attack the lungs. All sorts of bacteria will attack the lungs that are not normally can attack the lungs. So what you see with these kind of disease processes in AIDS is that the lungs white out at a rapid rate. Okay? And they have large problems with oxygenation issues, and as a consequence, they don't survive the event very well. The goodness thing is recently is that we've got the AIDS reasonably controlled in symptoms. We don't have it controlled in epidemiological circumstances, but we can treat most of the symptoms now, so it's much better than it used to be. It used to be a death sentence, pretty much. Suppurative diseases are things like bronchiectasis. It's dilation of the bronchi with local suppuration. You get affected bronchial loss of cilia in this kind of disease process. You can always pick up somebody who has bronchiectasis. You can smell them across the room. Okay? What's the #1 complaint they have when they come in to see you? Halitosis, bad breath. Okay? What they actually have is they have all these inflammatory cells that are developing in their bronchioles that they're forming pus inside there. When you actually do an actual bronchoscopy, the lungs are filled with pus, and the smell is something you just can't forget. Okay? The good thing is, if you don't have a nose like I do, I have a terrible nose, so I can't pick up smells that much. Nothing really bothers me. Okay? I see my other friends who've got great noses. They go to great wine parties and they smell, and they say, "Oh, this is great stuff." I say, "What are you talking about? Where's the oak taste? I don't get it, you know." But they come in the operating room and they're vomiting into the bucket, you know. It's like, don't that disgust you? I'm going, what smell? It doesn't bother me, you know. So I guess there's the benefits to everything in life. What you see is you see a productive cough with yellow or green sputum. They also get halitosis and hemoptysis, which I was talking about. They get crepitation because they'll develop pneumothoraxes, and they'll get little air bubbles underneath their skin. That's usually a bad sign. They'll get severe finger clubbing, and they'll get a reduction in FEV and FEC, so they get a restrictive disease component as well as obliterative disease component, which is some degree of obstruction. The last one we'll talk about today is cystic fibrosis on this chapter, and then we'll stop for 10 minutes. Cystic fibrosis is a genetic disorder. Okay? It's an unfortunate because it happens to individuals that are usually parents that are carriers and they don't know they have the disease. But then two parents come together that are both have this, they combine and they have a 50-50 chance of having a child that develops cystic fibrosis. Okay? And when they do this, what happens is that it's a disease of sodium and chloride transport mechanisms. And instead of the sole layer staying solvent, it becomes very thick. Okay? So anything that it requires is that kind of very solvent layer to be in place, so the pancreatic ducts, the lung will become affected by this. So these people, when you actually taste them, and that's used to be the test for in the past, they would tell you to lick the individual. Okay, you know, and I'm telling you, it's like, yeah, I don't think I'm gonna lick any kid anytime soon. The parents will, think it's some kind of whack job. Okay, it's not gonna happen. Okay, so instead, you usually ask the mom, "Does a kid taste salty to you?" And the mom usually will tell you, "Yeah." How do you know that? You know, because moms kiss their kids, so they usually will tell right away that kid tastes a little salty. They taste salty. Okay, they begin to extravasate large amounts of salt into their skin. It attacks the pancreas, so they get pancreatitis. They lack in their digestive enzymes, so these people have to be on specialized diets to break down the food, and also they don't digest things properly. It also attacks the lungs, and these individuals will have to have extensive pulmonary physiotherapy. So somebody's got to beat on their chest every day to bring up their mucus. They have to be put in a tilt table. So there's a lot of things that have to be done to keep these kids alive. The good thing is that things have gotten much better and they can live up to their 20s. But it's pretty much a death sentence around their 20s. Unless something else happens, which is they usually get a lung transplant. Okay, the lung transplants are usually now allowing these people to survive in their 40s, hopefully. But still there's a high mortality rate with transplantation, as you can imagine. So the pulmonary function is that you can get a significant VQ mismatch, and there's an early AA to O2 difference. So these people get certain degrees of hypoxemia that develop. Okay. Any questions? Okay, you guys got a 10-minute break.